you, Dr. Tiwari, for such kind words. And I'm going to talk about this very interesting topic about which we hear so much but talk so little. So this is actually one of the reasons why I chose this particular topic, and I'm thankful to Dr. Sabu and his team for giving me some chance to talk on this particular issue. So let us start with a case. And before that, I don't have any conflict of interest in my presentation. So this is a typical case of a cardiac autonomic neuropathy, which we often come across in our day-to-day scenario. So this is a 53-year-old female patient with type 2 diabetes who presented for a routine checkup. Her complaint was that she was having a transient giddiness and palpitations and waking up from the bed. 6 months ago, she was prescribed a combination of metformin and glimepiride. Over following 2 episodes of dizziness and palpitation during travel, she had been irregular about the therapy. And this is not a very uncommon scenario in our day-to-day practice, because many of such patients think that they're suffering from hypoglycemia and they just stop the medicine. So this was the case with her as well. On clinical examination, patient had a normal pulse and a clinic blood pressure, but from a supine to standing position, the blood pressure readings reduced by 24 systolic and 12 diastolic. So there was a postural hypotension. Examination of the foot revealed some degree of loss of temperature sensation. An examination of the eyes revealed a non-proliferative diabetic retinopathy. Now, the diabetes control was not up to the mark. HbA1c was 8.4, triglycerides was 180, renal and liver function tests were within normal limits, and the resting ECG did not show any abnormality. Now, the continuous glucose monitoring, which was done in this particular gentleman, in this lady, showed an increased mean amplitude of glycemic excursion. So that means the patient's glycemic profile was obviously not up to the mark, something which is not unexpected in view of an HbA1c of 8.4. Now, the ambulatory blood pressure monitoring in this lady showed a nocturnal, non-dipping pattern of blood pressure with a 5% dipping of systolic blood pressure at night. Daytime blood pressure was normal. Friends and colleagues, let me just re-emphasize that this can be the typical presentation of a cardiac autonomic neuropathy. So without wasting much time, let us get on to the main points of discussion today. So these are the points which I'm going to cover today. What is the basic pathophysiology and epidemiology of cardiac autonomic neuropathy in diabetes? What are the contributory factors? What should be the approach in diagnosis? And what is the correlation with the prognosis of diabetes? So these are the 4 issues that I'm going to cover in my talk. So the first one, what is the basic pathophysiology and epidemiology of cardiac autonomic neuropathy in diabetes? Well, this is the important thing, and particularly in a patient of type 2 diabetes, this can be the first presenting comorbidity. Let us not forget that. And this comorbidity, which is a cause of increased mortality and morbidity in the long run, can actually present from the pre-diabetic stage. Now, cardiac autonomic neuropathy is usually due to an intrinsic autonomic neuropathy affecting the autonomic nerves supplying the heart. And this is usually because of a direct inflammatory insult. So what is that source of that inflammatory insult? Let us not forget, friends, that adipose tissue is a big source of cytokines. The adipose tissue releases the NF-kappa beta, which basically stimulates the synthesis of pro-inflammatory cytokines like IL-6 and TNF-alpha. And this promotes the liver synthesis of acute phase proteins such as CRP and PI1. Now, what is important is that we also know that there is a significant role the liver has to play. So obviously from the adipocyte, it's this NF-kappa beta is released and the cytokines are released from the liver as well. Now, also it is important is that they can predate the onset of metabolic decompensation in a patient of obesity and metabolic syndrome. In other words, it may not always be due to dysglycemia. It is not the sole risk factor. Other factors like obesity, hypertension, and dyslipidemia are an equally contributing factor to the cardiac autonomic neuropathy. And some recent studies have shown that emphasize the role of the gut microbiome. And these gut microbiomes, it has been shown that they increase the release of metabolic endotoxins, and these gut microbiomes facilitate the absorption of this metabolic endotoxins from the breakdown of the fatty acid into the system, leading to the formation of increased serum lipopolysaccharide. And this serum lipopolysaccharide stimulates the formation of the inflammatory cytokines, which affects the nervous system, including the autonomic nervous system. So this, in summary, is what I've been talking about right now. So when there is an increased serum insulin because of the insulin resistance and obesity, this leads to a metabolic decompensation leading to hyperglycemia and formation of the advanced glycation end products. At the same time, this increased serum insulin leads to a sympathovagal imbalance leading to increased sympathetic discharge. And this, in its turn, leads to what is known as a reduced vagal anti-inflammatory discharge. This together, it contributes to what is known as the perivascular adipose tissue inflammation. Again, this is mediated by the pro-inflammatory cytokines, and this leads ultimately to the early CV dysfunction. Now, the CV dysfunction could happen simultaneously by involvement of the coronary artery vasculature. So there are two things which are attacking the heart. One is there is an inflammation which is affecting the nervous system. On the other hand, there is this same inflammatory cytokines that are also affecting the coronary arteries. So it is a double insult on the heart, and the heart often succumbs to that. Now, if you look at the inflammatory markers and the correlation of this, is a very busy slide, but this highlights some of the inflammatory markers which have been shown to have an important role in the pathogenesis of cardiac autonomic neuropathy. And these are the inflammatory markers like IL-6, highly sensitive CRP, and nitric oxide. So to summarize this busy slide, IL-6 was inversely correlated to the total power of the heart and the low frequency power. So that means that the patient is having an increased tachycardia. That is something which is also influenced by this IL-6. IL-18 or the interleukin-18 and high sensitivity CRP are inversely proportional with the measure of the cardiac vagal control. So in other words, more the IL-18 and highly sensitive CRP, the vagal control becomes less. Both nitric oxide and endothelial nitric oxide synthase were positively linked with the cardiac vagal tone indices. And endothelin 1 did not show any independent association with the cardiac autonomic function parameters. In other words, what this particular slide has emphasized upon is the fact that these inflammatory cytokines, they reduce the power of the vagus. Or in other words, the parasympathetic influence goes down and the sympathetic influence goes up. This is in type 2 diabetes. What about in type 1 diabetes? What has been seen, and this is a very recent study which has been published just a few months ago, is that the cardiac autonomic neuropathy is directly proportional with the duration of diabetes in type 1 diabetes. So that means more the duration of diabetes, more the risk of cardiac autonomic neuropathy. And this can start from as early as 5 years after diagnosis of type 1 diabetes. And what are the contributory factors? In fact, all of these factors mentioned on the left, like albuminuria, elevated body fat, systolic blood pressure, diabetic retinopathy, dyslipidemia, arterial hypertension, all of this can contribute to the evolution of cardiac autonomic neuropathy. But especially, the importance is with these factors, that is elevated albuminuria. If the albumin-creatinine ratio is more than 30, in other words, when the patient is directly in the microalbuminuric stage, there is nearly a 6-time increased risk of cardiac autonomic neuropathy. If the advanced glycation end products are increased, there is nearly a twice increase in the incidence of cardiac autonomic neuropathy. Diabetic retinopathy increases the risk of cardiac autonomic neuropathy by nearly 3 times in type 1 diabetes. Arterial hypertension, again, also increases by nearly 2.5 times the risk of cardiac autonomic. So to summarize, nearly 2 in 3 patients with diabetes may have cardiac autonomic neuropathy. 1 out of 14 newly diagnosed type 2 diabetes patients have got autonomic neuropathy, that is cardiac autonomic neuropathy, or nearly 7%. 1 out of 20 patients develop cardiac autonomic neuropathy every yearly. So the figure varies between 4.6 to 6% per year. And as I mentioned, in type 2 diabetes, it can candidate the appearance of the diabetes. It can appear in the pre-diabetic stage. And following the diabetes or diagnosis of diabetes, 4% of autonomic neuropathy is noted in the first 1 year. 20 to 30% people develop autonomic neuropathy by the 5th year, and another 30 to 50% over the next 20 years. So I should say nearly 80% patients of diabetes in 20 years' time develop some form of autonomic neuropathy. What is important is to bear in mind in South Asians like us, polyneuropathy is relatively less common, but the prevalence of cardiac autonomic neuropathy is as high as Caucasians. And this also suggests the fact that the peripheral neuropathy and autonomic neuropathy may not always go hand in hand. This is again a schematic diagram of the nerve fibers. For autonomic neuropathy, usually the thinly myelinated and the unmyelinated fibers are involved. And this is the basic anatomical fact. So there is basically an autonomic sympathetic denervation. So autonomic innervation is basically the primary regulator of the heart rate variability in cardiac performance. What happens? This sympathetic stimulus comes primarily from the superior cervical ganglion. And what happens is that when this chronic hyperglycemia is there, it leads to a progressive autonomic neural dysfunction, and that parallels the development of the peripheral neuropathy. So it starts initially distally, and then proceeds proximally. In other words, this autonomic neuropathy starts in the apex of the heart and ultimately moves on to the base of the heart. And one of the earliest clinical indicators of the cardiac autonomic neuropathy is a decrease in the heart rate variability. How we're going to measure that, I'm going to talk about later on. And there is nowadays, we have got the technology by which we can find out which heart is suffering from this sympathetic denervation. So a metabolically stable 11-CHED, that is meta-hydroxyephedrine, it undergoes a highly specific uptake into the sympathetic nerve varicosities via the norepinephrine transporters. And this quantitative assessment of this particular product, that's 11-CHED, it may be assessed in independent LV regions. As you can see in the accompanying slide, in a normal individual, this area looks red. But as soon as there is a moderately reduced retention of this product, which happens with a sympathetic denervation, the color changes. And that's why if you're doing this particular scan, this nuclear scan in the heart of a patient of diabetes, you can find out what part of the heart is involved by the cardiac autonomic neuropathy. So what are the contributory factors to cardiac autonomic neuropathy diabetes? We have discussed some of them. In type 1 and type 2 diabetes, this particular slide gives rise to, this shows exactly what are the main contributory factors. Any of the contributory factors which increase the comorbidity in diabetes can contribute to the genesis of cardiac autonomic neuropathy. But for example, in type 1 diabetes, hypertension and retinopathy are very important, and also the duration of diabetes. In type 2 diabetes, again, that role of hypertension and retinopathy is relatively much less. What are the other factors we can see here? In type 2 diabetes, for example, also, this was again an Indian study which showed that any patient who has got a cardiac autonomic neuropathy has got a substantial patient presence of peripheral neuropathy, nephropathy, and retinopathy. And that difference is quite significant satisfactorily. The other factors which contribute, for example, is a reduced EGFR. So more reduced the EGFR, more is the chance of having a cardiac autonomic neuropathy. And the other thing which I mentioned is obviously the duration of diabetes. More the duration of diabetes, more the risk of neuropathy, and more elderly the patient, more the risk of the autonomic neuropathy. So this is what the scenario is in Indian patients. 32% of Indian patients that do not have any cardiac autonomic neuropathy, or at least it is not diagnosed. Around 25% have got an early cardiac autonomic neuropathy, and that involves only one abnormal parasympathetic test. 24% have got a definitive cardiac autonomyopathy, which involves at least 2 abnormal parasympathetic tests, and severe or advanced cardiac autonomic neuropathy when there is an abnormal both parasympathetic and sympathetic tests. What these tests I'm going to talk about. So what is the diagnostic approach? So obviously these are the symptoms which can lead you to a suspicion that this particular patient is suffering from cardiac autonomic neuropathy. It's a huge list. I'm not going into the full details of that. But again, resting tachycardia, loss of heart rate variations, orthostatic hypotension, postprandial hypotension, silent myocardial ischemia, and unexplained left ventricular dysfunction of hypertrophy in the absence of hypertension, QT segment prolongation, and dysregulation of the cerebral circulation, reduced sympathetically mediated vasodilation of the coronary vessels, and increased arterial stiffness, sympathovagal imbalance. All these things are suggestive symptoms of cardiovascular autonomic neuropathy. Peripherally, patients could be having an increased peripheral blood flow and warm skin, increased arteriovenous shunting, increased venous pressure, increased transcapillary leakage from the macromolecules, and increased dependent edema, increased medial artery calcification. All these could be indirect manifestations of cardiovascular autonomic neuropathy. So when should we test for them? So basically, in asymptomatic type 2 diabetes patients, it should be tested at the time of diagnosis. In asymptomatic type 1 diabetes patient after 5 years of the disease, and particularly if these 4 symptoms are present, that is resting tachycardia, QT segment prolongation, reverse dipping of the BP profile, and orthostatic hypertension, then it becomes mandatory to evaluate for a cardiac neuropathy screening. So presence of symptoms and signs often are not sufficient for the diagnosis, and screening for orthostatic hypertension is advisable for all diabetic patients. Orthostatic hypotension test, which is a very simple test, you check the lying and the standing blood pressure, is recommended yearly in all type 2 diabetes and hypertensive patients, particularly those above the age of 50 years. And cardiac autonomic testing can help to identify patients with poor exercise performance for whom you cannot do a TMT to find out whether they are having cardiac autonomic neuropathy. Cardiovascular autonomic reflex tests or CARTs are considered as gold standard, and we're going to discuss these parts. Now, one of the simple CARTs to evaluate the parasympathetic nervous system is a simple deep breathing test. On how you do it, the patient sits on a chair, breathing around 6 breaths per minute. You calculate the maximum heart rate minus minimum heart rate, and the expiration is to inspiration ratio. Now, normally this difference should be more than 15. When it is abnormal, this difference should be less than 10. This again is a manifestation of the decreased heart rate variability, which you find with the breathing. And the expiration is to inspiration ratio normally should be more than 11, and it is usually less than 10 when there is an abnormality. Now, the next common test which is often used, but again, this has to be used with a lot of caution, is the Valsalva maneuver. Before this August audience, I'm not going to discuss about this Valsalva maneuver, but basically the first stage is the stage of forced expiration. And in the stage 3, there is a release of the forced expiration. And stage 4 is when you get the longest hour interval, it's a continuous release of the forced expiration. So there is initially a BP increase, followed by BP decrease, and a reverse of the heart rate. So initially, the heart rate reflex bradycardia, followed by heart rate reflex tachycardia. So this is something which we have to bear in mind. Now, in the Valsalva maneuver, one of the important contraindications of doing a Valsalva maneuver is that it is not advisable in patients with proliferative retinopathy and patients with an increased risk of retinal hemorrhage, because it increases cerebral perfusion pressure and can precipitate a retinal hemorrhage. So the patient is asked to blow into a mouthpiece of a manometer and raise it up to millimeters or 40 millimeters of mercury for 15 seconds. And you calculate the difference between the longest and the shortest RR interval. The ECG should be on at the same time. The normal ratio, the longest is to the shortest, should be more than 1.21. Abnormal is less than 1.1. The third one, basically, which looks at the sympathetic nervous system, is the orthostatic, supine to standing heart rate response. So monitor the heart rate while the patient is supine and ask the patient to stand up. Record the heart rate at the 15th beat and the 30th beat, and calculate the RR interval between the ratio, RR interval ratio. The 13th is to the 15th beat. Again, normally it should be more than 1.04. Abnormal is less than 1. And this is basically the changes in orthostatic hypotension, which is seen in such patients. Orthostatic hypotension, again, is a BP measured in the supine, and then afterwards ask the patient to stand up for 3 minutes and calculate the difference in the blood pressure. In a normotensive pressure, if the normal decrease in systolic blood pressure, it should be less than 20 millimeters, and a diastolic should be less than 10. If it is more than that, then obviously this patient is having an orthostatic hypotension. In hypertensive patients, we usually settle for a reduction in systolic blood pressure up to 30 millimeters or below or more. The last test is the sympathetic nervous system, is the cardiovascular autonomic in this CARTS, is the blood pressure response to a sustained hand grip. So the patient is asked to apply pressure on a hand grip dynamometer with the dominant arm 3 times. Highest of the 3 readings is called the maximal voluntary contraction. And the patient is asked to maintain the hand grip steadily at 30% of maximum contraction for as long as possible, up to a maximum of 5 minutes. Blood pressure is measured on a non-exercising arm at rest and at the end of the grip. Again, normally the diastolic blood pressure should rise more than 16. If there is a cardiac autonomic neuropathy present, the rise in diastolic blood pressure should be less than 10. So basically, these are the ways by which we evaluate the heart rate test, the blood pressure test, and this particular slide summarizes what is the difference between abnormal and normal. Now, based on that, what are the findings in the patient with type 2 diabetes in India? This was again the seminal study by Boyan et al., who showed that resting tachycardia is present in around 17% of patients with diabetes with autonomic neuropathy. Around 56% patients with autonomic neuropathy have an abnormal expiration inspiration ratio. 42% have got an abnormal 30 to 15 heart rate ratio. 32% have got an abnormal Valsalva ratio. 11% present with orthostatic hypertension. And around 19% have got an abnormal BP change in response to a sustained hand grip. So this is, in summary, what is done to evaluate cardiac autonomic neuropathy. And as you can see here, a simple test like the expiration to inspiration ratio gives you a very good suggestion that this patient is probably having a cardiac autonomic neuropathy. you do not need to take this patient to an abnormal Valsalva test. So resting cardiac tachycardia and orthostatic hypotension, these are some of the important features or the important features of cardiac autonomic neuropathy. But again, there is a differential diagnosis which you have to rule out. You have to look out whether the patient, when the patient is having resting tachycardia, you have to rule out the presence of anemia, hyperthyroidism, and fever. These are the three differential diagnoses of resting tachycardia, and also some cardiac abnormalities like atrial flutter fibrillation, adrenal insufficiency if the patient is smoking, if the patient is on alcohol or caffeine, and some drugs. These also have to be ruled out when you're evaluating resting tachycardia in your efforts to evaluate the cardiac autonomic neuropathy. Orthostatic hypotension similarly can happen because of intravascular volume depletion, acute blood loss, dehydration, cardiovascular disease, and acute shock, cardiogenic shock, and medications like the antiadrenals, hypotensive agents. This can all cause an orthostatic hypotension, particularly diuretics. This background history, as I mentioned on the left side of the slide, has to be fully evaluated if you're really evaluating a patient, if you're suspecting a patient is having a cardiac. Any biomarker, now this is a very recently diagnosed biomarker. This is known as the C1q tumor necrosis factor related protein 9, the CTRP9. This is a newly discovered adipokine, and these levels are measured by ELISA, that is enzyme-linked immunosorbent assay. CRTP9 levels decrease significantly, as you can see in the attendant graph. If the patient doesn't have cardiac autonomic neuropathy, the patients have got a raised level of this CRTP9. The more the patients have got definitive cardiac autonomic neuropathy, the levels decrease significantly. The percentage of definitive cardiac autonomic neuropathy was highest in the minimum quartile of CRTP9 level. So, as you can see, in the patients with the definitive cardiac neuropathy, nearly 55% patients had a reduced CRTP9 levels. So this is something which is very important, and this CRTP9 is also significantly associated with the other indices, the 4 indices of the parts that we have talked about. That is the breathing exercise, the Valsalva, the sustained hand grip, and the postural hypertension. These are all significantly correlated with the cardiac autonomic, with the CRTP9. This is still not available commercially, but I'm pretty sure maybe in the next few years' time, this will be a good test, which can probably help us in evaluating a patient with cardiac. This brings us to the last part of my topic. Does cardiovascular autonomic neuropathy adversely affect the prognosis of diabetes? The answer is an equivocal yes. Now, if this patient has got a resting tachycardia, an abnormal blood pressure regulation, particularly if it is a non-dipping or a reverse dipping. Now, what is a non-dipping and reverse dipping? Now, we all know blood pressure of all individuals, they dip when they're asleep. Now, instead of dipping, if there is an upshoot, this is known as a reverse dipping, and if the blood pressure simply does not drop during the sleeping phase, that is a non-dipping. So both non-dipping and reverse dipping are abnormal signals, which suggest that the patient is at risk of having an adverse cardiovascular outcome. Orthostatic hypotension under any situation, it produces a lightheadedness, weakness, faintness, a visual impairment, syncope. All these features, if they're present, it suggests an adverse cardiovascular outcome. An orthostatic tachycardia or bradycardia and chronotropic incompetence, standing, presenting as a lightheadedness, weakness, faintness, dizziness, all these, or even a syncope, these are all adverse prognostic indicators from the cardiovascular angle. So what we know, that cardiac autonomic neuropathy is a definitive and an independent predictor of mortality of type 2 diabetes. This is irrespective of whether the patient has or hasn't got any coronary artery disease. It is strongly associated with an increased mortality, and in some studies with an increased morbidity, as I've shown, like lightheadedness, syncope, and so on and so forth. And there is also an increased risk of such patients of having a stroke, having a coronary artery disease, because I've mentioned the same inflammatory cytokines which lead to the cardiac autonomic neuropathy also predisposes to a coronary artery disease. Now, diminished Valsalva heart rate ratio, as I've shown here, was significantly associated with the development of what is known as a silent myocardial infarction. Now, baseline cardiac autonomic neuropathy, they have got nearly 1.5 to 2 times increased mortality risk. This was something which was shown in that study. Prolongation of QT interval is an independent predictor of cardiovascular death and all-cause mortality. Silent myocardial infection, ischemia in diabetes patients can either result from a cardiac autonomic neuropathy, from an autonomic dysfunction attributable attributable to the cardiac pulmonary artery disease, or from both. At a sudden unexpected death, a sudden cardiac death, which is a known issue in patients with type 2 diabetes, often it is ascribed to hypoglycemia, but this is more predominant in patients with cardiac autonomic neuropathy. An imaging of the myocardial sympathetic innervation has shown that predisposition to arrhythmias may be related to the intracardiac sympathetic imbalance. If there is more parasympathetic denervation or more increased sympathetic innervation, if there is a more reduction of the vagal tone, there is an increased risk of this sudden cardiac death, sudden risk of sudden arrhythmias, and ultimately sudden cardiac death. The final take-home message is that cardiac autonomic neuropathy is not uncommon presentation in patients with diabetes, but you have to be on the watch out to make the diagnosis. The predisposing factors include a long duration, a presence of a poor glycemic control, but again, let me re-emphasize, this is not the only factor. In fact, patients could be having a reasonably good glycemic control, but because of the other factors like obesity and dyslipidemia, they run a risk of having cardiac autonomic neuropathy. Other comorbidities like nephropathy and retinopathy also contribute to the development of cardiac autonomic neuropathy. Presence of other macrovascular comorbidities like coronary artery disease and hypertension, they worsen the prognostic outcomes. Loss of heart rate variability, as I told you, this is one of the earliest markers of cardiac autonomic neuropathy, and this happens primarily because of the sympathetic denervation. And diminished Valsalva heart rate is associated with an increased risk of silent myocardial infarction. This is something that is very important. If you find any of these abnormalities during an autonomic nerve testing, then you have to be very, very careful. And sudden cardiac death, as I mentioned, from ventricular tachyarrhythmias remains a potential hazard in patients with cardiac autonomic. I end my presentation here. Thank you very much, Team RSSDI, and thank you, Dr. Valsalva, for giving me a chance